Welcome to our Medical Necessity Webinar Series Part 1. We'll begin at the top of the hour. The webinar will begin in 1 minute. The webinar will now begin.
Good afternoon to some of you and good morning to others. Welcome to our webinars, our series of webinars on navigating medical necessity. And we're very pleased to have you here. My name is Jeff Schiff. I'm a pediatrician and have worked extensively with Medicaid, including as the Medicaid medical director in the state of Minnesota, as well as now as a senior scholar at Academy Health and a consultant to the Catalyst Center. It's a pleasure to have you all on board, and we hope this webinar series is informative in your practice and in your hopefully for some of you who are families in the lives of your families as well. We are doing this in a series of 3 webinars, which I'll get to in a minute. And I'd like to say that this is a joint effort of the Catalyst Center based at the Boston University, which is supported by HRSA, the Department of Health and Human Services, with an award of $500,000 and no financing by non-governmental sources. The contents are those of the authors and not necessarily those of the official views of or any endorsement by HRSA, HHS, or the US government. The other collaborating partner here, and it's been a pleasure to have this collaboration between both organizations, is the National Coordinating Center for the Regional Genetics Networks. And that project is also supported by HRSA with a cooperative agreement for $800,000 a year. And like the Catalyst Center, this information and the conclusions are those of the authors and should not be construed as being an official position or policy of HRSA, HHS, or the government. These webinars are available for continuing medical education through the American College of Medical Genetics and Genomics. They're designed for one AMA Category 1 credit. And after completing the evaluation, within 30 days, the credit is available. And I will encourage you to complete the evaluations and give us feedback as we go forward, because our goal here is to make sure that this series is useful to all of you. We have financial disclosure policies that we encourage you to look at. I will say that in the ACMG is very careful about this, and the content and branding and financial disclosure and mitigation procedure are available at these websites. To go over this group is the program committee, and you'll see a number of us are speaking today. Some people have reviewed, and there is for some financial disclosure. I will say here, I'm not sure why it's not showing up, but everyone has nothing to disclose except Julie Kaler, one of our presenters, is an employee and at Garden Health. So I'll just say that and we'll keep moving. I'm not going to say anything more about this. And then I want to get into now our learning objectives a little bit. And I guess I want to just say one or two housekeeping things first before the learning objectives. We have a Q&A that's available, and we'll encourage folks to add questions in the Q&A during the entirety of this, and it's being monitored so we can bring them up for discussion at the end with our group of presenters. I also want to say that if you have a question that's more clarifying in nature, if you would highlight that in the beginning of your question, so we might get that answered as we move along. So we have questions more at the end for discussion. Our learning objectives today are to define medical necessity, to describe how evidence is evaluated, to determine whether a test or a service is deemed medically necessary, and to explain how evaluation of benefits and costs, explain how the evaluation of benefits and costs to families and to payers are considered when determining medical necessity policy. Okay. As I said, this is a medical necessity in 3 acts. We're on Act 1. We will talk about medical necessity. And here we really wanted to talk a little bit about the definition and the use of evidence. In webinar number 2, we will talk about Medicaid and EPSD and collaborative agreements and how states work at that level for a little bit. But then we also want to start the discussion of the practical application of medical necessity and I think that's where a lot of people have a lot of their own, I would say, lived experience. And in webinar number 3, our crescendo of our 3 acts, we will talk about the practical applications of medical necessity and probably talk more about payer authorization, about requesting authorization, and about denials and appeals. I want to give acknowledgement to the other people who are on and will be presenting with me today. Julie Kaler is a certified genetics counselor who, as I said, works on the authorization side. Demetrius Nance is not here today. Unfortunately, she got called away, but she is the Ohio Sickle Cell Health Advocates family leader, and has that wonderful perspective. Nicole Geisy, I hope I got that right. Nicole is a family leader from Arizona, and we'll be talking from a parent perspective. Erin Beaver is the licensed certified genetic counselor in Missouri and has been involved in the Heartland Genetics Collaborative. And then Tammy Jones is a program coordinator for genetics, metabolic, nutrition and research, and the MN4T4P program at Emory. And Tammy, you have to tell us what that stands for because I don't remember. I apologize. But anyway, I want to keep going. And I think it's really exciting now that we have the opportunity to get into the meat of this a little bit. So here we go. I wanted to say that our goal here is to understand how evidence is evaluated to determine if, when, under what circumstance a test or service is deemed medically necessary, and to understand who is making the determination and the process being used. So I think we really have two parts here. One is what's the evidence, and then the other is how is that evidence translated into policy at that level. And I think that I really want to say now, because I feel like when we were doing the planning, it was like holding back a dam because everybody really wanted to talk about a lot about the processes of prior authorization. And I really think that that's super important, which is why we're committing most of our time in the next two webinars to it. But today we're going to try to focus on how do we look at evidence, and then how does that evidence get translated into policy. So a definition of medical necessity, if you will. Okay, I'm getting used to my controls. I apologize. Medically necessary services are healthcare services or supplies needed to diagnose or treat an illness, injury, condition, disease, or symptoms, and that meet acceptable standards of medicine. And that sounds pretty logical and simple, but when you start taking that apart, there's a lot to this definition. This is a definition from HHS. But a couple of things. One is, I'm going to just take this apart so we can all think about it together. Healthcare services. For a long time, healthcare services were thought of as things that were provided by a licensed provider, be it a genetic counselor or a physician or a nurse, but not by somebody who wasn't the licensed provider. Now we think of healthcare services and we bring up questions like, where do doulas fit in? Where do community health workers fit in? So healthcare services is going through its own sort of evolution of what is covered. Illness, injury, condition, and disease. What are these? Well, I think we all have some sense of this, but who gets to decide what they are? And I think there are some big challenges right now that certainly we have seen. Their challenges. I think the challenges that we see that are the biggest are in behavioral health. For a long time, some states did not cover addiction treatment, for example, until the opiate crisis sort of pushed that to the fore and then realized that needed to be done. But that was one example of a behavioral health service. We could spend some time talking about bipolar disease in adolescence and and how that coverage has changed. And then, of course, not to get into the controversy of the moment, but to acknowledge that it's there, is gender dysphoria certainly is a behavioral health issue that has come to the fore. And then the other big issue, I think, in getting to decide what conditions or the symptoms are treated is around how we look at home care and long-term services and supports. And so I'll just say that that the definitions are always interesting. I put up here for your knowledge this definition that's from the HHS, but also I think there's the 3 or 4 pages in the connection to the National Association of Insurance Commissioners, which are really the state where states regulate their healthcare insurance. Gives a good synopsis as well with a little more detail. So part of this definition, I think that's really important, is that the definition includes purpose and evidence, but it also includes mechanisms to provide a service. So when we work in Medicaid, for example, and I'll get into this in more detail in a little bit, is we can provide a service, we can provide evidence, but then the simplest example is you would like a surgeon to do an appendectomy. So you want the service to be provided at a hospital with a competent surgeon and a good OR staff, for example. So the mechanism is also part of it. I'm going to talk about this a little bit along the way, but I wanted to acknowledge that in this realm of defining the evidence and where the service gets provided, the ACMG practice guideline on exome and genome sequencing for pediatric patients with congenital abnormalities and intellectual disability is we could spend a whole webinar taking apart in a good way how this practice guideline was constructed as a means of looking at evidence. And we'll talk about it a little bit, but won't get into the exquisite details of that, but was really well done. So under purpose, I want to just talk a little bit about this definition. And this is just another definition that gives a little more detail, but to prevent, diagnose, and treat medical conditions. And it includes treatment that includes curative care, treatment to ameliorate pain and suffering, and care that is designed to rehabilitate to the highest level possible. And I want to just say here that that preventive care should be added to these as well. And now, I guess I'll say just a couple other things. Nowadays, we talk about this purpose, and it gets, again, in another way, it gets a little confusing because social determinants, screening and treatment, which I think there many of us realize is super important, is now part of diagnosing and treating. And there are economic and relational factors involved in people's lives that, although they're not exactly healthcare services, we certainly know now more about their impact. And so, we can ask ourselves things like, if food provides, if good food decreases the cost of healthcare services and improves health, should that be part of healthcare? So I think we're undergoing a major conversation in this country around this. So I want to go now to a little more detail about evidence and its and evidence of purpose. So in states generally, and I'm going to speak first from the Medicaid point of view, and then Julie's going to talk a little bit about this from the private sector point of view. In states, there's generally a definition either in statute or in state rule that talks about prevailing or generally accepted definition of medical evidence. And so it says things like this medical care meets the generally accepted community guideline. And I think that over time, as the world's gotten smaller, and we know now that generally accepted is probably much more of a national guideline. A few states have incorporated in their rules evidence-based standards. And I think that that's important because, as we'll talk about here, we'll spend a lot of time talking about evidence. States use a variety of sources to get evidence of medical information. The Cochrane reviews are very well known for looking at evidence. I put down here, and I think we forgot to take off, what does it stand for? MED is the Medicaid Evidence-Based Decision-Making Project at the Oregon Health Sciences University. And I'll tell you that a large number of states, around 20, use this collaborative membership organization to look at medical evidence for topics that are relevant and often controversial, and then use their evidence to create their own state policies. The MED does not create its own evidence, but it digests the evidence in a very thorough way for Medicaid leadership. ICER is the Institute for Clinical and Economic Review, and is a really interesting organization that actually looks at what is always controversial, and that's what the cost in terms of the quality of life and of how much an intervention affects the quality of life. We use that a lot when we were looking at hepatitis B treatments when they were $100,000, to say how much does this cost compared to its benefit. And in England, the National Institute for Health and Care Excellence, NICE, I like their acronym better than ours, is a very useful thing. I think we have to acknowledge that in America we don't look at cost, we don't look at evidence and quality over value as much as it is done in other countries where it's brought in more clearly. But I have to tell you that states very clearly look at that. And when a new intervention comes along and one person in Wyoming needs an intervention that costs $1 million, the people in the Wyoming Medicaid program pay attention. So I think it's really important. The quality of evidence is looked at, and we're going to pivot to that in just a second in some detail. And then I want to just talk about how states actually digest this evidence and come up with their own their own policies or protocols. I had the pleasure for many years of being a medical director in a state, and the medical directors often get called in to look at especially controversial or expensive things. So the medical directors have a very active listserv. There was a discussion on the listserv just this week around looking at prenatal DNA and its effectiveness and whether it's covered and how it's covered in different states. Technology assessment committees provide guidance to states, and some states have these very open and public committees that look at criteria for anything from implantable spinal cord stimulators to autism treatments. And we had one of these in Minnesota, and I'll talk a little bit about how those committees work as well. Some states have these, and it's a very public. Minnesota has one, Washington State, Oregon, and I'm sure there are others that are not coming to mind, but it gives a chance for there to be public comment and for these decisions to be more transparent. Every state does have a drug formulary committee that looks at the criteria by which certain medications are covered. For almost every state, there are too many things to look at, and a lot of them are that are less controversial are handed over to vendors who actually do the literature review and create criteria. And then I think the other thing that's really important to know in states is that and I'm sure many of you know this, most states have a Medicaid program that subs out most of their care to capitated prepaid managed care programs. And the managed care programs, depending upon the state and their criteria, will have some criteria themselves for different things. But as we'll get to in the second and third webinars, they'll also have different processes for looking at authorization. I can think of examples here of things like autism services and medical home services and how those were authorized and paid for. So I want to talk a little bit about how states look at evidence and then Julie and I will share the stage here. So this is how we looked at evidence in Minnesota, and I do this as an example, but many states have something similar. So first we looked at the quality, the quality of care, and we looked at evidence the use of evidence was done. Consideration was given to the available scientific evidence and professional standards. And there's a need to be flexible to permit exemptions. And that's especially true, actually, it turns out, for children under EPSDT, but we'll talk about that next time. But I think the next bullet's really important, that sometimes the evidence runs out. And sometimes there needs to be a consensus in the medical community that's used when there's no definite evidence that exists yet, and the evidence is insufficient. So that's where I bet a lot of you have lived at some point or another here. And then healthcare services and technology must provide a net health improved net health outcome, which sounds obvious, but a recommendation necessitates good evidence that the procedure is effective in reducing morbidity and mortality. The medical benefits must outweigh the risks. And I'll tell you that we often in Medicaid would get, I guess I would say, services that were questionable as far as this is concerned. Somebody had a device they thought was that was approved, but the standards for approval for some things didn't necessarily meet the evidence standards that we had. And they have to be at least as beneficial as an established service. And they have to be available and usable outside of an investigational setting. So I think that's really important. Sometimes people have a great result in an investigational setting, but not necessarily you don't necessarily know whether you can implement that more broadly. So that's the first part. The second part for states is really around value. And I think that this gets a little tricky, but I just want to make sure we talk about it a little bit. Is the service that's being covered more effective than other services? Can we look at cost effectiveness as a decision-making guide? And in cost effectiveness, we have a few things that I want to just talk about a little bit. Is it at least as effective and less costly than other alternatives? Is it more effective or more costly but results in a much better outcome? Or is it less effective and less costly, but the outcomes that from the use of more expensive alternatives don't justify expenditures? So I just want to talk about these for a little bit because I think it's important. Something that is as effective and less costly for us was birthing centers, for example. They're less costly, they're as effective. Another example was advanced dental therapists taking the role of doing some procedures for dentists. Things that are more effective and more costly, but resulted in better but justified additional expenditure, for example, were hepatitis C drugs. They cost more, but the cure rate was very high. And things that were less effective and less costly, we would get, for example, requests for inpatient smoking cessation for a patient who needed a lung transplant, who had failed outpatient therapy. And at that point, we had to say something and sometimes say that there was a very little literature that inpatient smoking cessation was going to get that patient to stop smoking so that they more effectively than outpatient. Anyhow, we want to talk more about evidence and about who it applies to. And I'm going to turn this over now to Julie, who's going to discuss value a little bit more, and then start the discussion about how we look at the levels of evidence. Julie, are you there?
Yes, absolutely. Ready to.
I think I'm your advancer. So go ahead.
Wonderful. Thank you. Yes. So coming from the commercial payer perspective, our commercial insurance providers in the US are quite varied in terms of how they operate, what their focus is, and who their primary customers are. And so we'll hang out on this slide for a little bit and discuss what are the key attributes that kind of go into that value equation and how different commercial payers may consider or not consider some of these attributes. So in crafting a policy, which may include a medical necessity definition, payers often may not have those resources to review all this robust evidence in-house. So they may outsource that to third parties, just as Dr. Schiff mentioned, the states may do as well. They may, if they're a part of the Blues organization, rely on Evidence Street to use their sample policies, oftentimes just using those word for word, cutting and pasting them as their own policies. And then they may utilize other tech assessment clearinghouses, such as Hayes, Milliman Care Guidelines. There's several out there. Or they may have benefit managers and outsource this process to other folks like Evacor, AIM Specialty Health, Avalon, Concert Genetics, that can really advise and maybe have the personnel on staff to craft meaningful medical necessity criteria or policies. And in this equation are these kind of 4 domains of benefits and then the costs. So we really, in that value equation, think of what's the benefit over cost. And if we have a nice positive number, we've got value. What I would say is traditionally in that upper left-hand quadrant, most payers and most medical necessity definitions rely strictly on net health outcomes. This can be defined as changes to medical management that ultimately lead to a healthier person. It could also be characterized as medical decision-making. What treatment did we start or stop? What imaging did we start or stop? And it may be disease informed, like overall survival or progression-free survival for cancer. Or we might be looking at hemoglobin A1C in other disorders. So we might be looking at disorder-specific indicators of improved health. And these are often measured in the short term because long-term collection is pretty challenging. And those of us working in genetics know that we're already starting with small, rare populations. To assess them over years is an additional challenge that's really hard to demonstrate in that way that payers are used to seeing or would like to see. And what I would challenge is that the upper right and lower left-hand quadrants, the patient or family reported outcomes and health-related quality of life outcomes are actually incredibly important. And payers may be able to use them in defining medical necessity for genetic testing if there were maybe more clear language around that and clear collection methods. So for some payers, it's very important to have a member-focused and member-impactful policy. And we can demonstrate that with these patient or family reported outcomes. Additionally, health-related quality of life outcomes are increasingly recognized in other areas of medicine, such as physical rehabilitation and cancer care. And I would love to see these wrapped up more in our genetic studies. I think some of the genetic policy writers in our space may consider these quadrants personal utility, but I would challenge that's probably poorly defined. And there are actually metrics and language out there to bring a more official and evidence-based approach for all these wonderful things that genetic tests give us outside of a direct net health outcome that can be tricky to measure. And then finally, process and innovation. How are we increasing access for members? How are we assuring that the testing that we do has quality? That's all part of our medical necessity in our review and evaluation of a genetic test. And then finally, Dr. Schiff is right. While the definition of medical necessity is statutorily prohibited from bringing in cost, how we craft our coverage policies certainly takes cost effectiveness into account. Often, a less nuanced or maybe less sophisticated policy approach will consider only the cost of the testing. I think most of us are familiar with early exome coverage days. It was so expensive, right? But what we learned with good evidence is that actually there can be costs of downstream services, either rendered or avoided, cost of overall healthcare utilization. If patients and families have an answer, maybe they're not running to the ER at every fever. Maybe they have a network of resources to feel comfortable that they know what the condition is. And also many indirect costs, such as transport, medical food and devices, or human capital, lost wages and lost productivity. Thank you, Dr. Schiff. I think next we'll talk about some of that different tiers of evidence and how it might be weighted differently for evidence review for a policy point versus those of us practicing in the field, how we kind of think about it. There's certainly different opinions on what makes the highest quality evidence, but certainly systematic reviews and meta-analyses combining multiple studies are a really key evidence base that helps us know that a service, a test, a diagnosis is feasible, is reliable, and leads to better outcomes or just a better situation. What I think we all may bump up against, if most of the genetic counselors I knew sat down with most of the payer policy writers that I knew, we would probably agree, we would love to have this evidence in genetic testing. However, we're working with rare populations, difficult to reach or serve populations, and this evidence takes years and years and years to collect to get up to this meta-analysis level, whereas genetic testing might already be obsolete. So there's really a difficult, it's a difficult approach to have this high standard in a rare or rapidly moving field. And that's where all of our good accumulation of evidence comes in handy. Experimental studies, randomized control trials, those aren't just for, research. That can be done in a prospective clinic environment. And I think most of us in the practice out in the field, we really look at evidence-based practice guidelines. And I just wanted to call attention to ACMG's recent efforts to craft evidence-based practice guidelines, the most recent of which for whole exome sequencing. And that is a perfect representative of what payers can use to drive policy, whereas the previous statement from 2015 was simply a points to consider. It wasn't an evidence-based clinical guideline. It was a professional consensus opinion, and it wasn't able to be used by payers in this evidence framework. And on the next slide, we have a similar pyramid that I wanted to highlight, whenever we're looking at evidence for therapeutics, treatments, or impact to health outcome. Randomized control trials that are largely powered are really great, gold standard considered by some. But what I also wanted to point out is maybe level 3 down there in the dark blue. If you're practicing in the clinic, the best evidence you may have to go on is an NSGC or ACMG practice statement, position statement, consensus opinion. And these are certainly very powerful. We love our consensus statements and practice opinions, But from an evidence quality and a payer review process, unless it's an evidence-based clinical guideline, which has a rigorous methodology to it, these expert consensus opinions don't hold the same weight. So while we in the clinic may say, I need to do this because my professional body says so from a liability standpoint, we're ordering microarray as a first tier test in a patient with autism, then that's wonderful. But a particular payer may say, well, that's based on, a professional society opinion, not an evidence-based clinical guideline. So it's just helpful for us to know and understand some of those sources of friction that we can actually overcome, as ACMG is doing with these evidence-based clinical guidelines. Thank you, Dr. Schiff. I think I'll turn it back over to you as you kind of discuss some key areas in the strength of evidence.
Great. I want to thank Julie and thank you all for hanging in there during the lecture part of this. But I really think that it's important to understand this sort of, I think all of you know, because of the field you work in, that the evidence is not perfect. So, and I think what we're really trying to show here today is how the policy side looks at that and how to approach it. I really just want to say, in my interactions over the last few months as we've been planning this, the ACMG has really done a lovely job of trying to make sure that its guidelines are free of bias, or that the biases are identified. And I think that's super important, because other organizations have lost credibility around some policy making because they have some institutional or some, sometimes some pharmacological organizations are actually helping fund them. I want to talk about now how this evidence rolls up, because in the pyramid, we often get to this grade of evidence, which is really where both the ARC and a lot of other organizations have used this to look at a consensus about rating the quality of recommendations. And this comes down to anything. I'll tell you a personal example. I'm in the age range where I need to worry about aortic aneurysms. There's a guideline that says I should be screened once because of my age, but my father had one and my uncle had one, and there's no other recommendation right now. But the great evidence for screening once is good, and if you're worried, I'm okay. But I just wanted to just bring that out, because I think it's important that these things change and that they look at sometimes something very specific. But the strength of evidence really looks at some principal domains I want to go over. And these are, I think, really well worked out, and they're really worth thinking about. Bias. So who paid and who benefits from study results? We always look, I think, when we see the results, to find out how free they were of bias. Consistency. Do all the studies agree? And are there studies that occur outside the research setting? Because sometimes you get studies that go in one direction and then in a different direction. I can think about estrogen for perimenopausal women, and how those studies went back and forth for a while. Directness. There are two types of directness, I think. One is the study specific to the problem or the population? So sometimes people will come in and argue, for example, about medication assisted treatment after an overdose, but I think some of those studies have to look at how quickly somebody got on a medication after an overdose. And then the other type of directness is, do the studies compare the same thing? Comparing one drug against an existing drug for the same problem versus comparing an old drug to a placebo. You may get better results comparing to the placebo, but I think you're not really comparing what's out there in the real world. And then precision. Is there a dose response that makes sense? And is the higher the dose response relationship, the better off we are sometimes. So if giving you could look at the dose response to COVID vaccines and argue that there was some precision there. And then are there risks that need to be considered on the other side of the precision that we need to make sure of? And then the last thing, which I think is really important also, is publication bias. It's interesting to somebody who's been around for a while that there are more studies now that look at a big issue and then show no improvement with a certain kind of treatment. And sometimes those big studies need to be done and the publication, if there's less publication bias, a well done, thorough study that puts a question to rest is really important, even if it doesn't support a treatment, for example. I want to talk a little about what Julie talked about when she was talking about like things on level 3, for example, of her pyramid, because I think it's important to know that that not everything can be done through a randomized control trial. So sometimes the evidence comes from multiple series, and things that are looked at when you look at observational methodology is the magnitude of the results. Biases that all point in the right direction. So if there's a bias that may be built in, but it actually makes it more likely that the result is true, that's possible. And then a dose response gradient. It's always hard when the number needed to treat for is very, very high to have a small effect, and then somebody wants to put an expensive therapy into practice. So all of this combines into levels of grades of evidence. And this is what we looked at in the policy world a lot, and what I think you guys should look at. And the grades are they're debated, and but they're pretty simple. They're high, moderate, low, and I guess I would say it's important to distinguish between low and insufficient. So low may mean there's a lot of studies, but the quality of the studies is not good, and insufficient just means there's not enough evidence. So I think that both of those things are important to take note. The last thing I want to do before we open this up for a little bit more discussion is I want to talk about what I said in the beginning, the mechanism to provide the service. And without going into too much detail about this, I want to say that in the authorization and the policy that gets built around things, there's often discussion about the type of service, the scope, like for whom, the scope, I'm sorry, by whom. So who provides the service, the frequency, the duration, and where it's provided. And so, for example, I'm going to just translate this into some genetic counseling. Well, the type of services may be a diagnostic test. The scope may be by the right lab, for example, that's credible. The frequency often is once if it's a genetic test, but in other things it can be more frequent, like, and then I think the duration is, the duration about how much is provided, again, doesn't apply for like a genetic test, but could apply for like a physical therapy or an autism service or something like that. And then the site where the service can be provided and by whom is really important, because, for example, and I think this is super important for you guys, is a test that's done with results that come back which are not interpreted properly can really be a challenge. So they really have to be associated with the right kind of counseling, et cetera. So at this point, we wanted to just open this up for a little, I guess I would say a little reaction. And we really have asked Nicole, and unfortunately Demetrius can't be here today, but we really wanted to ask them to talk a little bit with us now about, from a family perspective, about this process, because I think this process is often very hidden. And so we'd like to just, I don't know if you want to jump in, Nicole. I'm just curious, how much of this process to these questions, how much do you know existed? Have you participated? What's your impression of all this?
Yeah, thank you, Dr. Schiff. I appreciate you asking. And I would say Julie gave a really great example of the family perspective and the patient perspective. And am I aware of this process? Yes, but not more retrospectively than proactively. And really, when we were going through this process ourselves, I've gone through this a few different times. My husband had multiple diagnoses of melanoma, and we were trying to figure out why he had all of those diagnoses. And it was determined we couldn't do genetic testing because there was no family history, which was exactly why we wanted genetic testing done, because there was no family history. And we were given just very short answers as here's our request, here's why we can't do it. We weren't really looped in on that process. And I think it's really important for patients to have that conversation with their doctor, to understand that this is a medical journey, that there's an emotional, there's a financial, there's a logical, and a medical component. So it really needs to be approached holistically, of understanding why the patient is going through this process and how that process is ran and how that determines the quality of life and care of that patient. We've also gone through this process with our daughter, who has a rare genetic condition. And we didn't know that she had a genetic condition. We just knew that what was in front of us. She's not eating, she's delayed. And so we had no idea that we were on a journey. We just knew tests were being ordered and they were coming back fine. Chromosome analysis, chromosomal microarray. We didn't know we were on our way to try to get exome whole gene sequencing that would finally give us an answer. And it's interesting because my husband and daughter actually parallel this whole time. He was going through cancer in 2010. She was born in 2011. And we didn't know that they were both on their way to a genetic diagnosis. And our daughter would get one 2 years later. My husband wouldn't get his until several years later. We would finally get answers as to why he was constantly having these diagnoses of melanoma. So I appreciate this webinar is being done because it's obviously there's logistics, there's red tape, there's boxes that have to be checked for things to be done. But one of those boxes I think that needs to be marked is a conversation and an education with the patient and the family. It's not the provider is doing this for them. The provider should be really doing it with them, because this family is going to have this process with or without a diagnosis all their lives, and they won't always be your patient. But if you can come alongside them and guide them and help them understand this process and how it works, they're able to navigate it successfully themselves, and then possibly be change players and activists for what needs to be changed later on in life as well.
Nicole, did you ever get involved on the policy side of this, like going to like the insurer or to Medicaid or whatever and saying, have you considered this indication because it doesn't fit your guideline? Or is it been more on the side of, here's where your guideline is and here's why we fit it?
Yeah, that's a great question. For that specifically, we have not. It is a very complicated world, the world of insurance and different medical diagnoses, and
Right.
We are always learning. And so I have dipped my toe in to get involved in different areas of life and of the medical diagnosis and insurance policies. And as I've learned more, I've been able to continue to work in that area. But I will say that when we have our providers who are able and willing to take the time to educate us and help us as we're asking questions personally, that helps me able to get more involved actively, not just for myself, but for other families as well.
Yeah, thank you very much. I think one of the things I'm hoping that everybody gets out of today's webinar is that it's okay to write a letter or make a phone call or ask about how the policymakers are making their decisions and get maybe a little upstream from your specific issue. We are, as I'm being pointed out, going to run out of time if we don't keep going. So we're going to keep going here a little bit. And I'm going to just turn this over a little bit. I want to introduce Tammy, who is going to talk about a therapeutic case really quickly. And then we're going to talk about a diagnostic case. And then we're going to open this up for more discussion. Tammy,
Thank you. Thank you, Dr. Schiff, and all of those who are here. We're glad that you have joined us today. In this therapeutic case, I just want to present a case for a patient who had PKU. He was diagnosed with newborn screening as a young baby, and he was prescribed by the clinic dietitians and physicians to receive Phoenix 2, which is a metabolic formula that treats patients with PKU. He was insured. He was insured by a self-funded insurance plan. His parent worked for a small business. And in his case, there was an exclusion. He was covered up until the age of 14. So the patient turned 14, and at that time, coverage was no longer available to him. His mom reached out to our clinic, and we have what's called the M&T for P program, which is Medical Nutrition Therapy for Prevention program. And it's a state-funded, Georgia state-funded program under the leadership of the state, acquired by Dr. Ronnie Singh, who was a registered and licensed dietitian at Emory University, and she also holds a PhD. She was able to get this grant to help patients because we were running into cases such as this, where patients either they had Medicaid, now they've come and they've reached the age of 21, so now they no longer have coverage. And so clearly, how do you get the medical food that you absolutely have to have? Medical food is formulated to meet the distinctive nutritional requirements for a disease, inborn error of metabolism, prescribed and used under the supervision of a physician, and intended for the management of a specific disease. So looking at the next slide, we will determine some of the things to consider that cause barriers. Patients, sometimes their claims are rejected. There are other times where maybe they cannot afford the out-of-pocket cost. They may not be able to afford their deductible. They may not be able to afford just if they don't have insurance, then clearly they can't afford it because it's a really expensive nutrition that they have to have. In the case of this particular adolescent, it was like over $1,000 every month that they would be required to pay. It also, another barrier could be age-related, such as in this particular case, once the child turned 14, he was no longer able to receive coverage. Then there are cases where patients have absolutely no coverage at all, which goes back again to the inability to pay for that nutrition that they so desperately need. There are other times where the insurance may cover the medical food. However, it may be a stipulation where they will not cover it if it's orally fed, but they will cover it if it's, for instance, through a nasogastric tube, which oftentimes is not necessarily always the case. The patient may not need it and may have the ability to just consume that product orally. So these are some of the barriers that patients run up against. And then some of the things that we need to consider is when you're conducting a benefits investigation on behalf of a patient, you will either have the DME company do that, or you yourself as a care coordinator in a clinic may want to help the patient by looking into those benefits. Patients are quite unaware a lot of times of all the ins and outs of insurance and the right questions to ask. Some of the questions that you'll ask could be, is it stipulated that it has to be one route of administration? And on our next webinar, we'll go into more about the authorization process and different ways that we can help our patients navigate this so that they're able to get the nutrition that they need. And so again, we'll continue this case in another session. Thank you, Dr.
Tammy. And Erin, I'm going to ask you to go quick here because unfortunately we're getting short on time, but we wanted to also present a diagnostic case.
Yes, so I have the diagnostic case that we're going to be talking about throughout this series. This is a 5-year-old male who presented with developmental delay and autism. He has a history of 3 seizures in his life. 1 was at age 3 and 2 were at age 5. At age 5, because there were a number of things going on, the primary care did order a Fragile X test, which was negative. And then this had kind of given up on genetic testing at that point. This patient was then frequently hospitalized for respiratory infections and found to have an immune deficiency. And so at this point in time, the primary care is wondering, is there something more going on, and seeks referral to medical genetics. There is a family history of autism and varying developmental delays in 2 maternal male cousins and a maternal uncle. And there's an unexplained recurrent pregnancy loss for the parents. The parents are trying to seek answers as much as the primary care provider is. The family is really hoping to understand the prognosis for their child, what resources that they may need to be seeking for his current medical management, but also for the future and what the future might hold for him. They would like to understand recurrence risks if it's possible for family planning purposes, but their main goal is really the care of their child and making sure that he has all the services that he needs. So he is seen in medical genetics where he has a chromosomal microarray that's normal. At this point, genetics is pretty convinced that there's something going on. And so they would like to move towards doing a whole exome sequencing because this child does have a number of different features that are unique to his medical presentation. In genetics, the geneticist's goal is to understand what is going on. Is there an underlying hereditary condition? And if so, what is it? What other health concerns might arise? How can we be treating this child's current symptoms in the best way possible? And what does his future medical management look like? And so we'll just look at the next slide to talk about some of the pieces that we want to consider when we're thinking about moving towards getting a prior authorization, because many insurance companies do require us to get a prior authorization for whole exome sequencing. I will just briefly comment here that from a provider perspective, it's really nice if you can provide answers to some of these points on this slide within your clinical note. It really helps if you're not the person writing the letter of medical necessity, and it helps the people, the support staff in your office who might be writing that for you. So make sure to think about some of these things. I will also point out that not every insurance is going to be, not every payer is the same when it comes to the criteria that they're looking for. These are just examples of some criteria that are common among payers. And there is a bit of a difference sometimes in what you see criteria-wise and coverage-wise for like a patient who's on Medicaid versus a patient who's on a private insurance. And so some things that we would consider in this case is that we are hoping that this is going to impact clinical decision-making. Maybe that is in the realm of his seizures, or perhaps it's in understanding how best to treat his immune deficiency. Having the ability to say, if a diagnosis is made, we are going to do this, or we're going to stop doing this. Those are really great points to bring up within your differential of your clinical note. Understanding the different possible genetic etiologies and how those could play out as far as medical management decisions in the future. But this is a case that we'll move forward with in the series and talk through when it comes to prior authorization processes.
Great. Okay, we are going to run out of time. There was one question that I saw in the chat I just want to address very quickly, and then we're going to wrap up. And that's really a great question, is how do you get the genetics providers and the payers on the same page? And I guess I have a couple just thoughts on that from being on the payer and on the provider side of things. You should really go to them and let folks know about what the relevant, how this lack of diagnosis, for example, is affecting the family, and how that could give them some rest, because the providers often don't hear that. I think it's important to come free of bias and know that you're free of bias if you're a provider, and often to tell the family story. I think one of the things that I found in this work and in some other work that we've done is that if you can create a relationship with the decision maker at the payer, you'll have a better chance than if you just send a letter into the void and don't hear back. So I encourage people to actually try to get these relationships made so that the payers understand what the relevant issues are.
And
I'm going to.
I was just going to say, sometimes there's a backdoor opportunity there where your institution that you work for may already have a good relationship, their claims and billing department, or they may have recently resolved something with your local Medicaid. So there's probably some institutional support for that as well.
Great. Okay. I think what I really want to tell you is I hope this has whet your appetite for coming back with us on May 20th, when we're going to get more into the processes and the practical application of medical necessity, and hope that this base gives you something to think about in the meantime. Please fill out your CME and the evaluation so we know if we're on target for meeting your needs as well. And I think with that, we're I got to go to the next slide. Give me 1 second. With that, I think we're going to sign off here at this hour. So thank you very much. We'll look forward to seeing you on May 20th.